Welcome back to Med School Content. I'm excited for this one. Today we're covering bronchodilators, the drug classes that directly open up the airways. This is part of our drug classes series, and by the end of this video you'll know exactly which inhaler to reach for in the ER, why Pharmacology is in a league of its own, and most importantly, why Theophylline can actually kill your patient. Let's get into it. Before we dive in, quick disclaimer. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Bronchodilators come in 3 flavors, and it helps to understand them as a family before going deep on each one. First, Beta-2 agonists. These are the workhorses, the most widely used, and they work by cranking up CAMP to relax airway smooth muscle. Second, muscarinic antagonists. These are the anticholinergics, and they work by blocking the parasympathetic signals that would otherwise constrict the airways. And third, methylxanthins, meaning Theophylline, an old guard PDE inhibitor that's rarely prescribed anymore, but that the boards absolutely love. One critical framing point before we move on. All 3 classes open airways. Beta-2 agonists and Theophylline actively relax smooth muscle, while muscarinic antagonists prevent parasympathetic constriction. That's what makes them bronchodilators. Short-acting agents like Albuterol and Tiotropium are pure relievers, use PRN for acute symptoms. But long-acting agents, LABAs, LAMAs, are daily maintenance medications used for sustained bronchodilation. What they are not is anti-inflammatory. That's the domain of controllers like inhaled corticosteroids and leukotriene modifiers. Keeping that distinction clear will matter a lot when we get to treatment algorithms. Let's start with the heavy hitters, Beta-2 agonists. Think fight or flight. When the sympathetic nervous system fires, you need those airways wide open. Beta-2 agonists mimic that signal. They bind to Beta-2 receptors on airway smooth muscle, which are G's protein-coupled receptors. Activation adenylyl cyclase increase CAMP protein kinase, a smooth muscle relaxation. Now, notice something important. Theophylline works on the same pathway, but it comes at it from a completely different angle. Instead of increasing CAMP production, Theophylline blocks the enzyme that breaks CAMP down. That enzyme is called PDE. So both drugs end up with the same result, elevated CAMP, but through entirely different mechanisms. That connection will matter when we get to the Theophylline slides. Now let's talk about which Beta-2 agonist to actually use, because the difference between SABAs, LABAs, and Ultra-LABAs is clinically huge. SABAs, short-acting beta agonists, are your Albuterol, your rescue inhalers. Onset is 3 to 5 minutes, duration 4 to 6 hours. These are PRN, you grab them for acute symptoms. Then you have LABAs, long-acting beta agonists, salmeterol and formoterol. Both last about 12 hours, but there is a key difference. Salmeterol has a slow onset, while formoterol has a rapid onset comparable to albuterol. That makes formoterol unique. It's the only LABA fast enough to be used as both maintenance AND rescue in the AIR and MART strategy, where a single ICS/formoterol inhaler is used for everything. Finally, Ultra-LABAs, indicatorol, albuterol, volanerol, these last 24 hours for once daily maintenance. Here's the critical safety pearl, and this is one of those facts you absolutely cannot miss. LABAs must never be used as monotherapy in asthma. Early studies linked LABA monotherapy to increased asthma mortality. The safety studies that followed Ostri-Vestri showed no increased risk when LABAs were combined with ICS, so the rule today is simple. If you're giving a LABA for asthma, ICS must come with it. Every time, no exceptions. Most patients tolerate inhaled Beta-2 agonists well, but at higher doses or with systemic absorption, you start to see the sympathomimetic effects. Tremor is the most common. That's direct skeletal muscle stimulation through the Beta-2 pathway. Then tachycardia, palpitations, and at higher doses, hemodynamic changes. Beta-2 vasodilation can drop diastolic pressure, but loss of Beta-2 selectivity at high doses can also cause hypertension via Beta-1 effects. Here's a metabolic pearl worth knowing. Beta-2 agonists cause hypokalemia. The mechanism is direct. CAMP activation drives potassium into cells. If you have a patient already on diuretics, this matters. You can also see type B lactic acidosis, non-hyposic, driven by increased glycogenolysis. And critically, if a patient is using more than 1 canister of a SABA per month, that is an independent risk factor for asthma-related death. That's not just a marker of bad asthma control, it's the drug itself contributing to risk through tachyphylaxis and altered airway dynamics. That frequency of use should always prompt a treatment escalation conversation. If you're finding this content helpful so far, take a quick second to hit the like button and subscribe. It really helps the channel grow, and it helps more medical students find these videos. Alright, let's keep going. Now let's flip to the other side of the autonomic nervous system. While beta-2 agonists amplify the sympathetic open-up signal, muscarinic antagonists work by blocking the parasympathetic close-down signal. Here is the physiology. The vagus nerve tonically releases acetylcholine, which binds to M3 muscarinic receptors on airway smooth muscle, and that causes bronchoconstriction. Muscarinic antagonists block those M3 receptors, removing the parasympathetic braking signal. They don't actively dilate airways the way beta-2 agonists do. They prevent the airways from being constricted in the first place. A few important nuances. These drugs have a slower onset than beta-2 agonists, so they're less effective for acute bronchodilation. They're also designed to minimize systemic absorption, which is why the anticholinergic side effects are much milder than you'd see with systemic atropine. And in COPD specifically, this is a key fact. LAMAs reduce exacerbations to a greater extent than LABAs, which is the opposite of what many students expect. Tiotropium is your prototype, and it earns that title through the UPLIFT trial, 4 years, 5,993 patients, showing sustained lung function improvement, reduced exacerbations, and reduced hospitalizations. Let's talk specifics. For short-acting muscarinic antagonists, ipratropium bromide is your drug. It's short-acting 4 to 6 hours, and in the real world, you'll almost always see it combined with albuterol as combivent or duo-neb for COPD exacerbations. That combination is standard first line for acute COPD flares in the ER. For long-acting LAMAs, tiotropium is the prototype, but the class also includes umeclidinium, aclidinium, glycopyrrolate, and rivafenacin. Tiotropium, umeclidinium, and rivafenacin are once daily, while aclidinium and glycopyrrolate are twice daily, but all are long-acting maintenance agents. Side effects are mild. Dry mouth is by far the most common complaint. In elderly patients at higher doses, watch for acute angle closure glaucoma, especially if you're using a nebulizer and the mist gets in the eyes, and urinary retention, particularly in men with BPH. Narrow angle glaucoma is a contraindication for the entire class. And now for the most board-tested bronchodilator that you'll probably never prescribe, Theophylline. This drug is related to caffeine. It's from the same methylxanthin family, which is actually a useful teaching point for its toxicity. Mechanism: Theophylline inhibits phosphodiesterase, which breaks down CAMP. Block PDE-CAMP stays elevated bronchodilation. It also has anti-inflammatory effects at sub-bronchodilator levels, and it blocks adenosine receptors. That last part is what makes the toxicity so dangerous. Theophylline is an oral drug which sounds convenient, but the trade-off is a narrow therapeutic window. Target serum level is 10 to 20 micrograms per milliliter. Below that, no effect. Above that, you start seeing toxicity. And because it's metabolized by CYP450, its levels shift dramatically whenever a patient starts or stops another medication. It's now rarely used for asthma. There are simply better, safer options. You'll occasionally see it in severe refractory COPD as a third-line agent. The way I frame it for students, Theophylline is the digoxin of lung disease. Technically it works, but it's a high-maintenance drug that demands constant monitoring. Here's the slide you need to study for your shelf. Theophylline toxicity follows a predictable triad, and it progresses in order. First, GI symptoms, nausea, vomiting, abdominal pain. This is your early warning. If a patient on Theophylline is complaining of nausea, check the level. Second, neurological, tremor, nervousness, and at truly toxic levels, seizures. Third, and most dangerous, cardiac arrhythmias. Atrial tachycardia, atrial flutter, potentially fatal. This is because Theophylline blocks adenosine receptors. the same receptors you rely on when you give adenosine for SVT. And that sets up the classic board question. Patient on theophylline presents with SVT. You give adenosine. Nothing happens. Why? Because theophylline has already blocked the adenosine receptors. You need to know that. For drug interactions, CYP450 inhibitors increase theophylline levels and push patients toward toxicity. The big ones are cimetidine, ciprofloxacin, erythromycin, clarithromycin, and verapamil. Inducers like phenytoin, rifampin, and carbamazepine do the opposite. And remember, smoking induces CYP452. When a patient quits smoking, their theophylline levels can rise significantly. Mnemonic: think of it as too much caffeine. Sick to your stomach first, then shaking, then your heart racing out of control. So how does all of this come together in practice? Let's talk about where these bronchodilators actually fit in treatment algorithms. For asthma, the GINA 2019 guidelines made a landmark change that you have to know. SABA-only treatment is no longer recommended at any step. The old approach of use albuterol when you feel bad is gone. A new paradigm, the AIR approach, says that even for mild asthma, every reliever dose should come with anti-inflammatory therapy, specifically ICS with formoterol. The rationale is that even mild asthma can be fatal, and pure bronchodilator use without ICS leaves underlying inflammation untreated. So in practical terms, step 1 to 2 in GINA, you use PRNICS/formoterol. Step 3, you add daily maintenance. Step 4, you escalate ICS/LABA. Step 5, you bring in biologics and potentially LAMA add-on. For a severe asthma exacerbation in the ER, the cocktail is nebulized albuterol every 20 minutes, plus ipratropium for severe cases, systemic steroids, and IV magnesium for very severe refractory cases. In COPD, the framework from Gold 2024 uses ABE grouping. Group A gets a single bronchodilator, your choice. Group B, more symptomatic, gets LABA plus LAMA right away because dual bronchodilation is superior to either alone. Group E, those with exacerbation risk, also gets LABA plus LAMA, with ICS added if their eosinophil count is 300 or higher. And there's now evidence that triple therapy, LABA plus LAMA plus ICS, actually reduces all-cause mortality in the eosinophil high COPD phenotype. The big takeaway, in asthma, every bronchodilator dose should come with anti-inflammatory coverage. In COPD, dual bronchodilation is king. Screenshot this slide. This is your one-stop reference for bronchodilators. 3 classes, 10 parameters, and the board pearls that distinguish them. Let me run through the highlights. Mechanisms: Beta-2 agonists increase CAM through adenylyl cyclase. Muscarinic antagonists block M3 to prevent bronchoconstriction. Theophylline blocks PDE to prevent CAMP breakdown, plus blocks adenosine receptors. Key drugs: albuterol for short-acting beta-2, tiotropium for long-acting anticholinergic, theophylline for methylxanthins. Adverse effects: beta-2 agonists cause tremor, tachycardia, and hypokalemia. Anticholinergics cause dry mouth primarily, with glaucoma and urinary retention in elderly. Theophylline causes the toxicity triad, nausea, seizures, fatal arrhythmias. And the board pearls: LABAs never as monotherapy in asthma. SABA overuse means death risk. LAMA beats LABA for COPD exacerbation prevention. SVT plus theophylline means adenosine fails. Know these cold. That's bronchodilators, 3 classes, 1 goal: open airways. Beta-2 agonists amplify the fight or flight signal through CAMP. Muscarinic antagonists block the parasympathetic braking signal at M3. Theophylline inhibits CAMP breakdown and is the most board-tested drug you'll rarely prescribe. If this video helped you, smash that like button and subscribe so you don't miss the next one. We're covering inhaled corticosteroids next in the drug classes series. See you then.